Welcome to the Guy's Cancer Centre. Go small, reach far, moving from a hospital to a distributed campus of care. Before I talk about what this concept means for Guy's and St Thomas's hospitals, I want to manage your expectations right up front. I'm afraid I'm not able to tell you how we successfully designed and built a hospital fit for the mid-21st century because we haven't started yet. We definitely have had some recent experience designing and building a new patient-centred cancer centre and a new children's hospital, and these experiences have helped shape our thinking. But what I'd like to share with you in the next 12 minutes are the ideas and ambitions of a group of us working at Guy's and St Thomas's to be truly transformational in the coming decade and beyond. The hospital as the towering cathedral of care, as the iconic focus of medicine, really only began its ascent in the late 19th century and reached its zenith in the late 20th century. It is our belief that the hospital is already in the descendant and it will cease to be the main focus of healthcare by the mid-21st century. That's only 30 years away, and so this next decade will be the time to begin dismantling the cathedrals and replacing them with a different kind of iconic structure. Why is the iconic hospital as we know it reaching the end of its sell-by date? Why does the cathedral need to be dismantled? It's because something is happening in medicine that has never happened before. The pace of change in the evolution of medical care has begun to accelerate at an exponential rate for the first time in recorded history. Medicine is now evolving so fast that major new treatments and methods of delivering care are emerging every few months rather than years or decades. What is causing this acceleration? It seems that three transformational forces are at play. These are technological advances in genomics and the other omics, advances in artificial intelligence and robotics, and the application of systems science to healthcare. Atul Gawande rightly called the 21st century the century of the system. The way in which these three forces interact will completely transform the way medicine is taught and delivered through health systems. And the impact of these three colliding forces will be so cataclysmic that by 2050, I'm not even sure the words doctor and hospital will have much meaning, certainly not the meaning they have now. To use an evolutionary analogy, hospitals are currently the evolutionary equivalent of a T-Rex, a supreme apex predator evolved over centuries to adapt perfectly to the social and technological forces of the 19th and 20th centuries. But the three new transformational forces, the omics, AI and robotics, and systems science, are the evolutionary equivalent of a meteorite hitting the Earth. The current species of hospital cannot survive the impact. If I can stretch the evolutionary analogy a little further, the healthcare equivalent of the small furry animals will inherit the earth. If we were to summarise our vision for the future of the hospital in 4 words, it would be go small, reach far. What does that actually mean? For us at least, it means that the purpose and function of a future hospital will be transformed to becoming a coordinator of a distributed campus of care. It will still be a provider within that campus, but a provider of much less care. It also means minimising the footprint of the hospital space used for the science of treatment. And even inside that smaller space, shifting the balance of activity from being predominantly the science of treatment to being predominantly the art of care. That's the go small. It also means decanting and distributing as many interventions as possible outside of the hospital space, mainly into the community and the home. and using technology to extend the scope and geographical reach of prevention and health maintenance. That's the reach far. But it's also a second meaning of go small, because delivering those interventions in the community will require the design of a new kind of small, iconic space. So how small can we go? Almost certainly much smaller than we think. Diagnostics, outpatient ambulatory care consultations, pathology services, even centralised surgical operators, none of these will be predominantly delivered in a hospital of the future. But how do we make sure we don't throw the iconic baby out with the cathedral bathwater? In the UK, the National Health Service Hospital is an iconic structure in the true sense of the word icon. It is a representative symbol worthy of veneration. And the NHS hospital really is venerated by the British public. But why? Probably because for us, the hospital is the physical embodiment of the NHS and everything that it stands for. The National Health Service for the British people is like your mother. We can moan about her, but heaven help anybody, including our own government, that criticises her or tries to mess with her. Our hospitals are probably iconic for other reasons too. They are temples to our modern gods, science and technology. They are also currently sacred places where, for most of us, life begins and ends. And for some, they are places where miracles, i.e. cures, happen. If we accept that an icon has to be a physical place or space, it has to be a tangible thing to be iconic, and if those evolutionary transforming forces are leading to distributed campuses of care, going small and reaching far, then is it possible to go from large iconic spaces called hospitals to lots of distributed small iconic spaces? In other words, to go from icons to iconettes. We looked outside healthcare for that answer, and we found that for the tech company Apple, the answer is yes. Apple revolutionised tech retail with its Apple stores. They are small spaces that remain iconic of the company and what the brand means for its customers, and they echo the large, iconic Apple headquarters at Palo Alto. They are award-winning designs co-created by Apple designers working with leading architects, where the whole visitor journey is controlled and designed to maximise customer satisfaction based on extensive research of customer need. We also found a clue to how such an approach might translate to creating iconic small health spaces within a distributed campus of care, and we found it in Dundee in Scotland. The Maggie Centre for Cancer Care is not part of a distributed campus of care, but it is a wonderful example of a small, iconic, patient-centred health space, probably because it was designed by one of the world's greatest living architects, Frank Gehry, and co-designed with patients and the local community. So, if a distributed campus of care comprising a network of small, iconic community spaces with a coordinating hub space is feasible, could they still be as venerated, if not more so, than our current cathedrals of care at Guy's and St Thomas's? We think the answer is yes, but only if, like 500 plus Apple stores globally, every aspect of their function is designed from a deep understanding of the patient journey and needs, and if their design, user experience and cultural values are entwined with the identities of the NHS and local communities that we serve in South East London. We realise that if we want to achieve that, and this will be really hard for us, then like Apple, we will need to fully understand the anatomy of a healthcare interaction. Even more difficult for us, we will also need to serve purposes other than the main purpose of healthcare. To do that, we will need to embrace the concept of co-production, and we will need to address the wider determinants of health and a good quality of life. Co-production and the wider determinants. By co-production, we mean delivering public services in an equal and reciprocal relationship between professionals, people using services, their families and neighbours. Equal and reciprocal. When's the last time you delivered a health service in a truly equal and reciprocal relationship with your patients? Again, to find a good example of co-production, we had to look outside healthcare, but just along the river to the Tate Modern Gallery on the Thames, the most visited tourist attraction in the UK. Tate Modern is so successful because it used co-production to understand how people might use its facilities. What they created is a space within an old power station where swathes of their visitors never go upstairs to look at the art, but they do visit the bookshop, the cafe, they go to see the monumental sculptural installations in the Turbine Hall, or to have a large, safe, sheltered space for social gatherings or respite. In other words, they serve purposes other than the main purpose of displaying art. If our co-produced distributed campus of care serves purposes other than healthcare, then it must address the wider determinants of health, and perhaps even go further still and address the wider determinants of a good quality of life. As a former Director of Public Health working in a London council, it seems obvious to me that despite technological advances in healthcare, its interventions such as smoke-free legislation, tackling environmental pollution and the obesogenic environment, but also interventions in housing and education that offer the greatest promise for the biggest improvements in health and quality of life. So if I can summarise, we're about to embark on what will probably be a 10 to 20 year journey at least, in a mutual and reciprocal relationship with our staff, patients, local communities and other public agencies, so that in 30 years' time, Guy's and St Thomas's hospitals will be transformed into smaller, coordinating, iconic spaces within a distributed campus of care, full of even smaller iconic spaces which cannot be hospital-centric or even health-centric. It's the only way we can survive the meteor impact as an organisation, and the only way we can play a meaningful part in bringing about real and lasting improvements in health and well-being to the population we serve. Thank you.